Çiğdem,
So, as you all have been informed technically, this meeting is being recorded and will be distributed. So for the ones who do not allow their names and visibilities, please close your videos, pictures and names. And for the others, thank you for your confirmation for the recording. So it is my pleasure to host Professor Dr. Furkan Burak today, and our esteemed board member Hediye Güral will host the whole panel. But at first, I would like to welcome Mr. Dr. Furkan, and I would like to say that I'm so excited to hear about the hormone replacement and also the weight management, because it's something going in parallel, I guess. When you need the hormone replacement, then the weight gaining is become a new problem for that period of time, I guess. So to keep it short, I will hand over to my esteemed board member Hediye, and thank you so much in advance.
Thank you, Çiğdem. Dear IWF members and sisters from around different parts of the world, I would like to welcome you all. It is my great pleasure today to introduce you Mr. Furkan Burak, who is not only a very well-known and successful doctor in his field, but also a very valued friend of mine. Dr. Furkan Burak is an endocrinologist, associate professor, and a physician scientist leading a translational immunometabolism research program at Brigham and Women's Hospital, Harvard Medical School, and the Basic Science Research Group within the Department of Molecular Metabolism at the Harvard T.H. Chan School of Public Health. His work focuses on adipose tissue-derived signaling pathways in obesity and the development of next-generation therapeutics for immunometabolic diseases, including diabetes, obesity, fatty liver disease, and asthma. He is recognized for bridging fundamental biology with translational clinical innovation, contributing to emerging therapeutic strategies in obesity and metabolism. Dr. Burak has an extensive publication record in top-tier journals and has authored invited book chapters in obesity. His work spans mechanistic discovery through clinical application, with contributions to the development of novel therapeutic approaches in the field. He is triple board certified in internal medicine, endocrinology, diabetes and metabolism, and obesity medicine. His clinical practice focuses on obesity, diabetes, and complex immunometabolic disorders. He was appointed by the government of Massachusetts as the sole endocrinologist on the Mass Health Drug Utilization Review Board. He currently serves as chair of the obesity group at the Endocrine Society and as obesity section editor for the Journal of the Endocrine Society. He has been recognized as one of America's top doctors by Castle Connolly and Boston Magazine from 2026 through 2026. His work has been recognized with major international and institutional awards, including honors from the Endocrine Society, the United Nations, Bank of America Trust, the Blavatnik Foundation, Harvard Dubai Foundation, and NIH-affiliated programs. Dr. Burak, we can't wait to listen to you. Now it's your turn.
Thank you so much, Hediye. It's really a great honor to be here. Thank you so much for all the organizers from IWF. It's really an honor and a pleasure, and it's really special for me to be introduced from a sister, which doesn't happens frequently. We go through all around the world, but this is one of the very, very special event for me. So thank you so much for the invitation. And I know IWF is doing incredible things and hoping to contribute moving forward as well. So initially, I was planning to give hardcore what we do, and we very basically work on multiple aspects of metabolism and what happens from when you gain weight, what are things that are changing in a molecular level, and how we can address that to bring you back to factor settings to treat multiple diseases. But I think with the current environment, there are lots of unanswered questions, especially for women, so that I will focus first on certain aspects of women's health. That's why I said the beyond hormone replacement and weight management, because that's just one part of it. The paradigm really shifted for women's metabolic health, which is fascinating. So that I will talk a couple of them, and then at the end I will mention some of our work, what we do, and then I'll try to keep some free time so that we can discuss like a panel. So if I start with like what really changed that in the historical model, so it was, first of all, the weight management is important for everyone, especially, I mean, when you look at the weight management clinic, so I'm leading weight management and wellness center at Harvard, that our 80% of the patients are women. So women always think more about the details and in the same time punished more too. So in a way from peers or everything. So everybody was thinking that it was a willpower, and it was just a behavioral blaming that's really causing a huge issue, which really changed, and we understand that it's just the dysregulation of the energy regulation. It's nothing to do with the willpower, so which I will dive in. And then we were always looking at the numbers in the scale, which was also not telling the story, because now the more details are very important, like the body composition, how much muscle you have, how much fat you have, and is the fat under the skin, which is a great organ. If it's in the organ, it gives you the disease, and then what happens with the insulin biology and sensitivity. And then the menopause is a big focus and is a big change checkpoint in a woman's life. So where it was very hormone focused manner, are you going to get hormone or not, which that really changed that how we can really focus on the systemic metabolic resilience, which has many different things getting together. And you have to address in a comprehensive manner. And the end goal was really for more cosmetic outcomes, some hormonal fixes, some adds up. But now we, as I said, we really know that there is a very complex system biology that from a cardiovascular health to immunometabolism, immunity to all those metabolic hormones harmonies that leads to lifelong health span increase. So that should be how we see it. And as a symbol of it, that we always think about, so what do you mean? That even like the 100 years of a syndrome, like in Turkish, it was always like a PCOS. You heard like polycystic ovarian syndrome. That was like the name changed recently, very recently, like last month. So from a big consensus report and coming from patients too. Like previously, it was more about the cysts in the ovary, and then it was mainly addressed by OBGYN and focus on how many cysts do you have fertility or not, or do you have regular periods or not, which we understood that it's not that. It's actually now the name changed to PMOS, which is a polyendocrine metabolic ovarian syndrome, because this is a very systemic metabolic disorder that driven by insulin resistance, and there are root cause oriented management is more helpful, so that you address all the endocrine dysfunction, cardiometabolic risk, and lifelong systemic effects, because we know that when a young woman has PCOS or PMOS, that it predicts that women's metabolic risk for later. So we know that it predicts like 80 to 90% that we know that woman most likely will get metabolic syndrome, which has all the hypertension, diabetes, prediabetes, and problems, fatty liver disease, and which is top leading cause of liver transplants now, and insulin resistance. And then, so basically, this NIV syndrome has multiple parts, like even the psychologically that cause anxiety, depression in endocrine way. It increases androgen levels, high androgens, not really helping women. That's really causing irregular cycles, to many other things. Metabolically, they are very prone for type 2 diabetes, fatty liver disease. In cardiovascular way, it increased cardiovascular, even mortality through hypertension and dyslipidemia, and there are dermatological parts that coming from high androgens, like with acne and hair and some virilization, like male type changes. So that was kind of like a symbol. I'm not going to get more detail of it, but when you really look, there are many things changing from a female-specific metabolism now finally studied, because previously it was more about like studied in men and applied to women, which was the biggest problem of medical history, actually. So now we know that even in the inside, a healthy woman even has a different metabolism throughout the menstrual cycle that affects the insulin response. So menopause alters many different things. Like pregnancy is a metabolic stress test. It's not, we don't say, oh, pregnancy is not a disease, just deal with it. It actually is a stress test for a woman. And then the immune system acts differently than men. So all this autoimmunity, which happens much more problematic in women versus men. And now we are focusing on how we can slow down the ovarian aging that possibly might prolong the estrogen exposure, and then all others, which I will come there. And of course, everybody focus on now the current therapeutics like GIP, GLP analogs, the weight loss drugs that I will also mention. And when we look, as I said, like in menstrual cycle, for example, I'm just putting this as an example, it's one of the research, even in the insulin sensitivity is different, like how much glucose. The same person is not sick, same. Throughout the cycle, in the follicular cycle, the glucose goes down, insulin goes down. In the luteal phase, insulin and glucose goes up. So there is insulin resistance in the luteal phase after the ovulation. In the second phase, which in the other side is vice versa. So there are even a very personalized nutrition. Now the Nestle has a specific project that will basically tell that the women wants to eat different things here versus different things here, that has to be different products to be available. And then, of course, the main topic is the menopause. So menopause is a huge transition. It's like really a cardiometabolic turning point, because so before, women is protected against heart attacks and strokes and cardiometabolic events, where a woman lose that advantage with menopause. And after menopause, the hypertension goes up. And if you get menopause earlier you get into menopause, the cardiovascular risk dramatically increases. You can see it here. So age 50 versus 40, there's a huge risk difference for cardiovascular disease, basically heart attack and stroke. The bad cholesterol goes up, triglyceride goes up. They're actually, in the coronary arteries or the carotid arteries, the plaques start happening much accelerated way in the calcium scoring and everything. So, and then it's not just that. So when you look at the whole life, so there are more insomnia happening, the sleeping problems, sleep apnea goes up, the systemic inflammation goes up, and the insulin resistance get in, metabolic syndrome, type 2 diabetes. All of a sudden, their adiposity is increasing in visceral way. So basically, with the menopause, so there are 2 times higher, faster fat gain with the same amount of movement, same eating. Like you're not changing what you eat, you're not changing how much you move, but you're basically accumulating more fat in a wrong place in the organs. So that tells us that, of course, we need to handle this differently. And another thing is I think I would suggest everyone to look is a heart rate variability. I mean, especially in this in the business world, it's a stressful situation. The heart rate variability is like your heartbeat is not very regular. For example, if it's 60 per minute, it's not like every second's in the same. So there's a variability of it, and the higher the variability is better. So it tells you have greater autonomic flexibility, and basically cardiovascular risk is lower. And you can also more simplify that HRV tells you that did you recover to next day? I mean, you're having a stressful day, you're dealing with the business or anything else, or like, I mean, there are millions of a problem that comes in a day. So if you recover to next day, your HRV is higher. If you can't recover from yesterday, your HRV is still low, which tells you to slow down or address something else. So, and that changes, like in premenopausal women, the HRV is really high, and then perimenopausal going down, and menopause, like it all goes down autonomically. So you're losing your autonomic flexibility, how to deal with stress. Your recovery is getting worse as well. So that's why in this new era of menopause care, so that we just don't address, oh, you have hot flashes, it's night sweats, let's do something. So that's one part, of course, but we really focus on every organ systems, and as I said, like it's an immunometabolic resilience, which we still try to reduce your cardiovascular risk. We address insulin resistance, visceral fat accumulation, your cognition, the brain health, your sleep hygiene, and then muscle. I will talk more and more, sarcopenia, and your mitochondrial function, your energy, and your lipids, and many more, of course. I try to minimize things to talk more. And then the one of the biggest scandals to me, like from my standpoint, was how the world perceived the Women's Health Initiative, like WHI trial, which happened in our center at Harvard, but they unfortunately really read it wrong. That after this trial, so they just generalized this trial to every woman on earth, and then basically hormone replacement prescription fell, actually it's 80%, and then millions of women avoided voluntarily, and then all the benefits were delayed or missed, and clinicians also get hands off, and 24 years is one doctor generation almost that get this like feeling of, oh, no hormone. And that was wrong, because when you look at that study, people were like 63 years old, they're already out of 10 years of menopause, and they were taking basically a synthetic progesterone, synthetic hormones that is causing the problem for breast cancer, and then they were taking from the mouth as a pill. But we understand when we look at the subgroups, we found that it's actually, if you don't give progesterone, the synthetic one, by mouth, so breast cancer risk actually goes down, not going up. And then there were no increase in blood clotting, like pulmonary embolism, like thrombosis risk, or any other cardiovascular event. It was the vice versa. So actually, if you start in the perimenopause, if you start the hormone like a replacement, and if you give from systemic way, which is basically the skin, if you give the patch or gel, it does not go to the liver, because liver is the first place to get all those things that you take from your mouth. There's a first pass effect. Then all the blood clot factors synthesize in the liver. So if you bypass the liver, there's no blood clotting issues. And then actually it lowers the mortality. Like mortality is the toughest thing to affect on. It's like a 31% lower all-cause mortality and 30% reduction in the heart disease risk, like heart attack and stroke, if you start in the perimenopause or menopause plus 5 years and continue for 10 years. That's why they're saying like 60-10 rule, but simply everybody can personalize that. You know, you're getting in the menopause the final day and then add 5 more years, or before that menopause day, perimenopause. If you start, that's the white area that you actually should start the hormone replacement therapy, unless there's an absolute contraindication, which is very limited, like personal history of breast cancer is one. And there are like some genetic conditions, otherwise most of the times no. But if you pass that opportunity and you're already out of that window, so closer there, that there's a personalized decision has to happen, that become like a gray area. So that it's hard to say something very closely, but you have to weigh, like do the risk benefit analysis, which we can do with everyone. But now, so it was like last November that the FDA lifted the black box warning after basically 22 years and apologized for women. And basically now it's a standard of care, which I was doing this for 10 years. I took an activist position even at Harvard, said, you know, this was wrong. And I had my own menopause program to advocate for women, because when you utilize that, so the like fatal cardiovascular disease, heart attack, stroke that kills you goes down up to 50%. Or fractures going down 50-60%. I mean, one hip fracture, 1 year mortality is 50%. You can't just let it go. Vasomotor symptoms, I'm not even talking about it, that's all gone. So Alzheimer's disease went down, cognitive decline went down. There are many other things. So you have to think that previously, when, you know, your life expectancy was like around 50, 55 years historically, right? So if you get into menopause by then and everybody's dying, so that world it makes sense. But now people are living 100 plus, getting into menopause at 50 doesn't make sense, and it's not needed. So, and when you look at the aging, actually menopause really aging almost every organ system. And the biggest effect is in the immune system. And when you give estrogen, of course, there are different types of effect that reverse aging, and most of them, like heart, for example, is harder, pancreas is harder, but overall all reversed. And then immune system like gives you, if you take estrogen versus not, there's like a 5 years younger immune age, which is a very significant reduction. And we know from these KEEPS and ELITE trials that earlier you start is better for you. And then if you pass that 5-year period, then you have to personalize the risk. And then, so basically, as I said, with this metabolic resilience, so we really focus on your sleep hygiene, how much you can sleep, what is your quality of sleep, because that really disrupts many different things. And then we really look for your mitochondrial function, like your energy levels. Are you able to burn things in the right way? What kind of fuel your body utilize? What is your muscle utilization? So muscle and VO2 max is extremely important. So there are two strongest parameters of longevity. The first one is VO2 max, which is how much oxygen you can utilize to your cells and that get into the mitochondria. And the second one is how much muscle mass you have on your legs. So that's the strongest correlation, which I will come in. And your cognitive function is important, extremely important. So moving forward. And then, like everybody asks, like I can't utilize hormone, or I don't feel comfortable, but I have horrible hot flushes and night sweats. I cannot sleep at night. So what do? So there is a new FDA-approved drugs like neurokinin 3 inhibitors. So there are 3 of them, but one of them is already in the market, like fezolinetant, that it works very well. It's a non-hormonal anti-menopause vasomotor symptom drug that you need to know that it exists. And then the second one, we always address the questions. So the main problem with menopause was like everybody said, okay, this is what happens, this is the natural thing. So this has happened to my mom, my grandmom, I have to deal with it. I have to suck it up and whatever symptoms. So you're getting alone, and it's a horrible thing. It's like really, really hard to go through, which you don't need to do that. So you need to address what is changing, what and how I can actually prevent, and I keep my pattern going like as previously, which is scientifically proven that it should be. And that's why we like to track certain things, especially not for lifelong, but when you're in the transition period, you need to know what's going on. So that's why we like to utilize continuous glucose monitoring. So you put the patch, it measures every 5 minutes, it gives you all the patterns. So you track your sleep, how deep you sleep, so like how much REM sleep, like deep sleep, and do you get actual sleep, or do you need to do something there? HRV, we talked about it, extremely important for stress response. And the body composition is, I mean, everybody has to do it to see what is the fat mass and visceral adiposity. So how much fat inside the organs, which is the wrong place that is giving insulin resistance and all kind of other things, and muscle mass. And then all the metabolic metrics, how much energy you burn. Like, just don't say my metabolism is slow. We need to check, is it, you're utilizing more fat, more sugar, so what is the metabolic rate, and how we can fine-tune about it. And then hormonal state, of course, so that there are many different hormones that they work in a harmony, like from stress hormones to sex hormones to many other things that you have to monitor to kind of see. Because if you take a snapshot, just, I have checkup every year, it doesn't show you. So it's just show a snapshot that you don't get the pattern, and that's different from a different time of point. Even menopause versus menopause throughout the menstrual cycle, it's different. If your stress is different, certain days, like when you take a picture of snapshot, it doesn't give you the picture. So you need to recognize the pattern and take your action. And again, this is not for lifelong. Generally speaking, the longest is 3 months that give you the whole picture, but even as weak, as short as 1 week, sometimes it's enough to knowing the problems and going forward afterwards. And then everything needs to be personalized. Every woman is different, have a different life, different environment, different thoughts, different rights, different wrongs. So it has to be blended, and it has to be personalized and truly personalized, not like all this like marketing stuff. So you need to know that you need to get a personalized intervention. Certain dose is different. It depends on how much fat tissue you have, because it's going through your fat. So where do you live? So what kind of problems you have? Personalized nutrition is extremely important. What you can achieve, like what you can get, like what you can eat throughout your busy life. So, and personalized exercise is extremely important. Don't just push like with personal trainer. That you need to know, is there an asymmetric muscle strength, which muscles you need to work on, do you need more aerobic or more resistance, and everything. And then of course pharmacotherapy and menopause care has to be personalized too. And then I will talk about the muscle that is one of the most under-highlighted thing. I mean, now with the GLP-1s everybody talks about it, but the muscle is not a simple thing. So, and you don't look at, you know, your overall weight or BMI. Is even body mass index doesn't give you the thing, but really the muscle mass is extremely important, and the quality, because the muscle is the biggest organ that basically utilize all the glucose and give you many other things. So your functional capacity, it protects the bone and give you the necessary signal to the bone. So it's very, very important for your long-term health span. As I said, I just give one extreme example. If your leg muscles are weak, and 10 years later it can cause one fall, that fall can cause a hip fracture, and that can take like 10-15 years from your life. So this is extremely important, because we know that with the estrogen going down, the muscle you lose. With the menopause, we know that the muscle breakdown is going up. And unfortunately, this chronic dieting, you know, you start on Monday and stop on next Tuesday, is a huge issue. In this like chronic dieting is the worst thing you can do, that you lose muscle and then you regain fat. You lose muscle, you gain fat, which is really a big problem. It's really messing up with your autonomic nervous system too. And then of course everybody's using GLP-1s, so that if you do it in a wrong way, without resistance training and protein support, you're also losing your muscle, which we know this is like semaglutide, Ozempic, Wegovy, tirzepatide, Mounjaro, Zepbound. We know that if you just go by default, you lose muscle. And then in certain individuals, up to 40-45% of the weight loss is coming from muscle. Again, if you don't do the right things, this is not the problem of the drug. This is the problem of using the drug in a wrong way. But if you do things right, you don't lose muscle. So which is basically, it's also different for everyone, but we have personalized approach for it. And we know that, you know, this with the sarcopenia, which means you loss of strength, function, and mass of muscle. So that is extremely problematic in the long run, that it can increase falls and fracture, cause disability, metabolic disease, reduce your quality of life. And actually, unfortunately, it's shorten your health span and lifespan. So which we know that estrogen getting out is an issue. When you replace estrogen, that helps dramatically. And of course, with the nutrition, I don't have time, but you have to very focus on it. And then resistance training and weight training is extremely important with adding stuff. Because we know that even if you're on the Zepbound or Mounjaro, so this is like you lose very significant amount of weight, but if you add estrogen therapy to it, so basically it gives you 35% more weight loss, so while protecting your muscle. That's why I'm always thinking like, why we give up from estrogen if there's no absolute contraindication. And then what you can do is really resistance training. One thing that you have to do, little weight or everything counts. It doesn't have to be fancy gym, CrossFit or any other thing. So every movement counts, and little weights to little resistance against the wall all works. And then you need to optimize your protein intake, like 1.2 kilogram per day. If you can't get enough, if you cannot eat enough, you have to add kind of a clean protein powders, not the bad ones. That I have to say that 80% of the products out there has microplastics and heavy metals in it, so you have to be careful. And then you have to add like a 10 gram of fiber daily, like psyllium husk. Simple, but it adds a lot. And then you can get like creatine monohydrate that will help, because the women has 70-80% less creatinine. Collagen is not a complete protein, but you can supply to you. And then you have to focus on, as I said, your cardiorespiratory fitness. What is your heart reserve, breathing reserve, how much oxygen you can utilize when you're switching to lactic acid accumulation rather than utilizing oxygen, and your metabolic flexibility, as we talked about the HVR, and your bone density. So everybody getting into menopause should screen for osteoporosis and do necessary things. So the next question everybody asks is, what about testosterone therapy? Because I don't have enough muscle, so testosterone is making muscle, let's utilize testosterone, which is now is getting much more like incredibly utilization, because now we traumatized the society last 100 years about the wrong anti-obesity drugs, and now we got the trust back, but unfortunately that trust is being abused by non-medical providers with peptides, with like abuse of anabolic steroids for testosterone. Everything now it became like okay to utilize just to build muscle, to be more fit and stuff, which is extremely wrong and actually very concerning for us, because we don't want to kill the public trust again. That we know that if you look all of the trials, first of all, more hormones doesn't tell you you have better outcomes, and it doesn't support it that for muscle, for bone, for cardiovascular health, for cognition, feeling energy, longevity, there is no such evidence, and there are multiple things. There's only one indication of testosterone for women, which is HSDD, hypoactive sexual desire disorder, which is an important thing. So if you have this disorder, there's 11 international medical societies, this is a consensus report that if you utilize and the necessary amount of testosterone, that increase the desire, the arousal, responsiveness, orgasm, and the stress reduction. And gives, this is even not a miracle, it gives you more or less just one more satisfying sexual event, intercourse per month. So it's not like you utilize this and it gives you a totally different world. So, and if you utilize it, you still need to know that it still harms, that it can change your voice and cultural change. So it can have a blood thickening event, because we know that it does erythrocytosis, the solid parts of the blood getting higher, and thickening of blood is not good, so that it can form a clot and it can be problematic. The lipids are worsening, so LDL, the bad cholesterol, it goes up. Hirsutism, hair growth, acne, this can all happen. So generally the problem is the people are still using like a man level utilization with pellets, with implants, with intramuscular injections, oral formulations. These are all wrong and very dangerous. So it's just basically you increase your cardiovascular disease risk. But if you utilize, you have to use transdermal gel or creams with steady level, and you have to do like 1/10 of the male dose. Like you should not go crazy and should utilize very low levels that has been shown to have beneficial, and there's a maximum doses that if you want to know. But of course, ask your doctor. From here, so I'm coming more of a what video from this angle. So as I told you, that energy regulation is extremely complex manner. So there is a hypothalamus in the brain, is a basically appetite center. This neurons is working as yin yang. This tells you to be hungry, this tells you to be full, and it gives the signal to here, and there are higher kind of centers. This is a hedonic brain that is basically wants to be happy. It's like a reward center, but this is the place that tells you to drink alcohol again, eat the sugar again. You're not hungry, but you should eat again. You're stressful, eat again. So this is the place, and this tells you how much energy to burn. This one decides what are going to happen. So are you going to feel full or hungry, or you're going to burn the energy, or you're going to store the energy. But biologically and evolutionary, so this system try to keep you alive. So for survival, this system is utilized and created to store the energy and save the energy, not to utilize. So any weight loss, any decreased calories is a threat. It sends a signal to here, and this place, this machinery does everything to gain it back. So that's why when you just do a diet and exercise and you lose weight, and it's here is not happy, does everything to give you cravings or decrease your metabolic rate and gain it back. Again, that weight cycling is more problematic. So that's why the diet and exercise is never enough for weight loss. So it gets a lot of input from the body, like many different organs sense inputs, like leptin from adipose tissue comes here and tell how much energy store you have. But in obesity, for example, there's a leptin resistance. The brain doesn't know how much energy storage you have, so try to still find something and gain that. It's not about you. Then GIP, GLP is an incretin effect. When you eat a meal, they release from the gut, comes to here, say feel full, comes here and say stop looking for food, and then here tells you need to burn the energy and slow down the digestive system so you're not getting in to the blood right away. So, but in obesity, you lose this GIP, GLP response, which we call it incretin effect. So what happened now, all these hormones that we created biological forms of it, we know basically the sequence. So when we give these back, basically we can restore all these problems, and that's why, like, how these medications work. Like GIP, GLP analog is Mounjaro, or tirzepatide is Zepbound. GLP alone is this Ozempic. Now there's a GIP, GLP glucagon. Another one, it's retatrutide. So amylin is cagrilintide. These are all biological things that try to kind of restore what's broken, not like a willpower or something. And they're safer for long-term utilization. And what happens in the body, when you eat something you cannot burn that day, you store in the form of fat, and then once it's basically it's saturated, then the fat tissue becomes your enemy. And then all the energy start accumulating on your organ that gives you the disease. So weight gain becomes a disease when you store the energy in the organs. And we know that, there are more than 160 molecules, like 160 different type of medication for anti-obesity that is going through the phase 2 and phase 3, that there's a huge revolution out there, that Mounjaro is very old drug, Ozempic is very old drug, so there are multiple new forms are coming in. And then, of course, everybody asks, I don't have obesity, what about this and that? So we know that these medications are lowering the cardiovascular risk, less heart attack and stroke, so we utilize them for that indication. If somebody has a heart attack and stroke, we do microdosing, lower dosing. Not everybody has to do just by default things, so we know that these medications will be in everybody's life. It became like a pill form, and it's going to be like a $10 drug. It's going to be like aspirin. So we need to know how to utilize them. So never get dehydrated. So never lose your muscle. Get enough protein. Get enough fiber. Don't get constipated. So be active and sleep well. So there are multiple things that you need to do. If you just take the drug, you will deplete yourself. You will be dehydrated. You will be less energy. You will be depressed. You will lose your muscle. So that's the wrong way. And then, of course, we are saying it's not a lifespan, it's a health span, so there's a big gap now, so that it's increasing. The people are living longer in a wrong way. The disability burden increases. The economic burden is huge to countries, which none of the countries can handle this elderly population that has disabilities and chronic diseases, that we need to focus on the things early to increase quality of life and the health span, not just lifespan. So in the another thing what we do is, so we work on basically we're saying obesity is causing different type of diseases. I'm going to give you 2 examples of what we found. So we work on obesity-related asthma. So this obesity-related asthma, we discovered a hormone comes from fat tissue, goes to airways and causes asthma exclusively on women, and then with the weight gain. And it's non-allergic, there's no treatment. And when you look at the asthma patients who cannot be treated, so they have 80% plus obesity or overweight. And then we took the samples I'll show you from US and London, and we showed that our hormone was there. So now we created a new drug against it to treat, because it's more symptomatic, it's more problematic, there's no drug for it, and unfortunately these women are suffering. And this has been shown in first 1986, that obesity or being overweight increased the risk of asthma in women but not men. And then a big severe asthma research group in NIH US did the cluster analysis and found this cluster. So basically have obesity, only women, non-atopic is not allergic asthma, and it happens late onset. So you develop after 45, and it's extremely hard to treat and very symptomatic. and this is a birth cohort from New Zealand. So when they followed the girls from the birth all the way later and measuring new asthma, so that they showed that basically increasing BMI, become more overweight, that increase the risk of having asthma in females, but not in males. The same thing in North Korea in middle age, like the weight goes up, the asthma goes up in women, but not in men. So, and this is not a small portion of the problem for women. Like we're saying, more or less 28% of asthma developing in adult women is due to and being overweight and obesity. So that we need to address. So we have a big consortium in London that I'm leading the endocrinology aspects of it, that asthma like really kills and basically affect 4 times higher for women than men. And when we look, we are saying the endocrine function of fat tissue affecting women more than men. And we worked, I'm not going to get into detail, but we discovered one of this hormone called FABP4 coming from fat tissue, goes to airways, and normally in the airways there are some, but in obesity it goes up and it contributes to hyperresponsiveness and causes asthma. And then this molecule is not just causing asthma. In a setting of obesity, normally this is a physiological molecule, become an evil hormone that's causing multiple different problems: diabetes, asthma, atherosclerosis, diabetes. And if you delete it genetically, this mice is protected from all these diseases. Or if you're lucky enough, if you have mutation and you have lower level of FABP4, this human are protected from heart attack and stroke and type 2 diabetes. So when we checked the certain studies in humans, like this is Nurses Health study, female only, we also showed that this hormone is 30% higher in women with asthma than no asthma. And then when we look to their airway fluids, that's it was the same thing. It was regulated with obesity, and this is the same thing, but from a London, from a Europe cohort. So this hormone goes up with asthma, so that now we created the drug, and hopefully treat something untreatable. And this is an anti-FABP monoclonal antibody. This is a vaccination technology. So we created one molecule, blocked the FABP4, and we treated first diabetes. It lowered the fasting glucose. It treated diabetes. It reversed hepatosteatosis, fatty liver disease. So from this to this in 5 weeks. And then this is atherosclerosis. So this is vasculature, aorta, that it lowered all these plaques that will give you the heart attack and stroke. And then we said, what about asthma? And we treated the asthma model. So this is animal models, and it lowered this obese-related asthma. So now we are starting the human studies. The second thing we look, so we created a mouse, we deleted this FABP4, it became like a miraculous mouse. It becomes obese, so eating everything, has same amount of fat tissue, but do not develop any of the obese-related problems. So, and then we said, okay, what is different in this mouse? And when we look at their blood, that palmitoleic acid, one of the fatty acids, was 3 times more elevated. And then we established that, I'm not going to get into detail, that this is one of the rescue mechanisms of the body's own. So when you eat something, a glucose, a sugar, chocolate, you cannot burn that day. You store that in the form of fat. But while doing that, the fat tissue tried to save you. So fat tissue is sending palmitoleic acid to other organs and saying, I am storing this extra energy, you should not. And it sends to the liver, if I call it POA, it lowers fatty acid accumulation in the liver, so it decreases fatty liver disease. It goes to muscle, it decreases insulin resistance, so you don't get diabetic or you don't get the glucotoxicity. And it's also circulating in the circulation that it decreases the atherosclerosis, the plaques, and this heart attack, stroke risk, and the immune cells become like more calmed down. It has an anti-inflammatory effect, which I'm doing now the human clinical trial, which for the safety thing, I look for certain, this is going to be first in human trial because we developed the drug from outside. We said we're going to mimic the body. And Harvard asked me, what is your safety data? And I looked back and I found a fascinating story. So in 1950s, when they said fat is bad, which was a biggest mistake, everybody's get into this corn syrups and stuff, fructose syrups. Everybody get diabetic. only in Greenland, they only found 2 people. Then they sent a mission there in 1970s, found 132 Eskimos. Their first-degree relatives went to Denmark, living there, and they followed them for 4 years. And interestingly, the Eskimos were living on high-fat diet, and they were eating palmitoleic acid, 3 times more elevated. And when they look, actually, they had no diabetes, no coronary artery disease, no cancer, and despite their eating fat, the fat in their blood was much lower. Even triglycerides, that Eskimos living in Greenland, they had much lower triglycerides, much lower cholesterol, to the first-degree relatives who live in Denmark in a Danish diet, which has great pastries. And palmitoleic acid was become one of the most abundant fatty acid, so that now at Harvard, I'm running this clinical trial that we are giving palmitoleic acid to overweight people with prediabetes and for insulin resistance that we check. So I'm gonna finish with the time, but this is how we measure insulin resistance, because everybody speaks about insulin resistance. It's not a simple thing to ask. It's not like you just check your sugar and insulin and do HOMA-IR and speak about it. It's very misleading. So hyperinsulinemic euglycemic clamp is the gold standard test to measure it. So this is one of my participants who gave the consent to show. So this is a place that NASA built for us. So basically, the idea is we are giving high amount of insulin from one side, and then that would bring your sugar down, but we don't allow that. We always keep the sugar 90. So this is the part. So there is insulin in it with the person's own blood mixed, so as a carrier. And then you give variable amount of glucose, the sugar, to keep the blood sugar at 90 all the time. So if you're more resistant, you require less. You're more sensitive, you require more. So, of course, this takes like 4 hours to bring the steady state. So this is the hot box that we collect the blood with blood sparing technique every 2.5 minutes and create a lab. You cannot do it with the finger stick. And then there's a very complex mathematical formula that we measure what is the insulin resistance, how much body utilized, and the organ-specific sensitivities as well, so that we have blinded results that showing incredible differences. Since it's not done, I'm not able to show. After that study, which 8-week study, which we do incredible testing from MRIs to body compositions to all these clamp studies, the next study is going to be diabetes prevention, so that we're going to give this, because your body makes it and it exists in the food, like macadamia nuts, dairy products, so there's nothing more natural about it, but it always comes with a bad brother, palmitic acid, palm oil. So now we are separated that, so we have pure palmitoleic acid as a drug that we will hopefully utilize it for diabetes prevention and for the fatty liver disease. So this is our, we are very fat tissue focused group that we love fat tissue, because fat tissue is a fascinating organ. It's your friend. It gives estrogen with aromatase activity. You just need to keep the energy inside the fat. You need to keep the fat inside the fat. That will keep you happy. Keep your muscle. Do not have extra energy going out to the organs and cause a problem. Then now we have the ability to treat many different diseases, including aging. For us, we say fat talks and body listens. So we kind of navigate immune system to cardiovascular disease, the metabolic disease, all through the adipocentric manner. So thank you so much for listening. So this is my clinical group that I have a group in the lab as well, and my collaborators in School of Public Health. And I have 2 clinics in Boston. I'm at the Brigham and Women's Hospital at Mass General, and I have another group in Istanbul, Turkey at Flovel, Florence Nightingale Hospital. So I can stop and get the questions here.
So thank you, dear Furkan, for the informations you have shared with us today. I have suffered from pregnancy diabetes followed by insulin resistance for long years, but with the proper treatment, I am at the edge of perimenopause right now, but I feel really better and healthier compared to my younger ages. Thank you for that. I am sure that my sisters might have some questions. So, do you want to ask any questions to Burak?
I have a word. Such an amazing, outstanding presentation. I'm grateful for your time, Professor Furkan Burak. Thank you so much.
Sure, my
Thank you,
pleasure.
Çiğdem.
Thank you.
Any questions? I can see that you have informed us in detail, so everyone is feeling great about the presentation. I think there is no question here.
Actually, I have Hediyeciğim.
Okay, sure.
Hi, Dr. Furkan. Thank you very much for the very valuable information and recommendations embedded in it. I have two questions. If it is a post-menopause period, are the recommendations the same or would it differ?
So it depends on when you get into the menopause and how long you lived as menopausal versus, because when the estrogen is depleted or it's stopped, so the vessel walls is changing. So most things are changing. You have a reprogramming in the body so that if certain time pass too much, then reintroducing estrogen become more problematic. Like if you're talking about hormone replacement, certain things you cannot do as aggressive if you're menopausal for 10 years plus. Is this applied to everyone? No. I mean, I have 92 years old patients, at least like 50 of them, that they still on the estrogen. And also ethnicity is different. Like I have Russian patients, for them, it has to be there. So for many different things, for skin health, many other things, they're doing well. But can you apply this as a scientific recommendation for everyone? No. So if you are 5 years menopausal, white, you have to use it. If you're postmenopausal 5 years, you're all good. You can do it. Everything is white, clear decision. If you're outside that window, closer you are, you can still do it. And you can be more monitoring and stuff. So you would be more mobile, utilizing blood thinners and stuff like that. And then you can do like coronary CTs. You look your burden first. What is my coronary artery, plaque burden, calcium scoring, many other things. And if it's clean, then you can start. If the burden or problematic stuff is too much, then you have to do risk-benefit analysis. Depends on your age and your comorbidities, like comorbid conditions, other problems that you have.
Thank you. My second question is, after menopause, do the uterus and the ovaries continue to play an important role? This question is regarding avoiding the cancer risk.
Yeah, it's a big $1 million question. So technically, as of now, no. If now, it's actually an advantage if you don't have uterus after menopause, so that you don't have to take progesterone. You can just take estrogen only, and you don't have to be exposed to progesterone systemically because you don't need it. So that's become like an advantage. So ovaries, nobody knows that, it's after the menopause. There might be some roles, but as far as we know, there are not many roles after kind of that organ aged and not having any new hormone production. Everybody tried to see if there's anything alive. Is there any new protein expression happening that we can revitalize the ovaries? I think nobody really focusing on uterus much, but in terms of the ovaries, because they were such fascinating organs that has a machinery. It's like you have a factory that was fascinating factory. All of a sudden you close it. So some people think there has to be a way to awakening, for revitalize the organs. So that's why there are certain things, programs happening. But as of now, it's no. So for the cancer prevention, there are some groups that if there is any, you should not get a surgery for, of course, to prevent. But if you're getting certain surgeries postmenopausal, then some people just take it out.
Thank you.
Any other questions?
Voi, Mami. That's it.
Bella?
Just a moment. Just a moment. Wow.
Seems like Bella
Hello?
is a cardiologist.
Hi. I am very pleased to be invited, and I enjoyed your lecture. I think that it covered many important issues, and as a woman and as a specialist, I think that your lecture was brilliant. Thank you very much.
Thank you, Bella. Thanks for coming.
Okay. Bye.
Thank you. Anyone who wants to...
Berna.
Hello, thank you so much. Yeah, hello, thank you so much for the presentation. Really appreciate all the work you have been doing and you're going to do for us, really. So I'm really thinking this should be a continuous way of treatment that you're talking about, the treatment and the additives and everything. So I think we should have some place around us that will be really helping us with the procedure, with all the procedural stuff. So do you have, I'm living in London, so I'm wondering, do you have any organization you're binding around UK?
Yeah, I mean, I was born in Kent, but unfortunately I left the country a long time ago. So I'm working more with the non-profit organizations, doing like with the British government, we try to raise funds for women's health and for more research. So for procedures, unfortunately, I don't. But I have lots of friends that they're starting things that if I have a place that I can trust, I can tell to the organization. But if you come to Istanbul or Boston, so we have places that comprehensively, from your sleep to your stress management to hormone replacement to weight management, we provide all this thing in a comprehensive manner, from psychologists to physiotherapists to dietitian to physicians. So we work as one body. So that's my model, to address all in one place. Otherwise, if it's fragmented, it never works well. And it has to be longitudinal. It's not just one simple intervention. So whoever you find in London, so that make sure that they can provide everything or most of the things in a long time, not just 1 month, fancy, lights and stuff.
Yeah, that was that is a thing that I was thinking, because if you go somewhere for only one visit, visit, it's not going to work, I'm thinking. So it should be there. You have the treatment all the way for a year or two, as you just discussed. So yeah, I'm going to text you. I have your information details, so I'm going to link to you anyhow. Thank you for the presentation. Cheers.
Sure, my pleasure.
Any other questions?
At last, I want to thank Mr. Furkan. He diagnosed obesity for my son, and he cured my son. So I'm very glad. I am the mother of Ömer Tuna Çavdar. So sorry, I'm from the phone. I cannot open my camera, but we are very glad to know you. Thank you so much, Mr. Furkan.
My pleasure. Thank you so much. Best regards to family.
Thank you.
I think that's all for now. Okay, Furkan, thank you again for accepting our invitation and giving this incredible presentation to us. We are all very glad to know you. And if anyone needs your opinion, I think they are going to reach you. So
sure.
If there is no one to add something, I'm going to close the session.
Thank you very much.
Thank you. Thank
Thank
you.
you,
for
Mr.
coming.
Thank you. Bye.
Thank
Thank
you
you
for
so much.
listening to this
Thank you.
presentation.
Thank you so
Bye.
much. Thank you for invitation
Bye.
and doing great things
Thank you
at
so much.
IWF.
Thank you. And
Cheers.
Thank you so much.
we wish you success in your trials.
Thank you so much.
Thank you. Bye bye.
Thank you. Bye bye.
Bye.
Thank